evening, and I believe for some of our Japanese colleagues, it's good morning now. And welcome to the day one, session two of the INC 2021 annual meeting. I'm so happy that you are back with us. And I really also hope that you had a great time listening to the proceedings for the earlier this morning's sessions where we discussed landscape of sponsored clinical trials as it pertains to cell and gene therapies in the neonatal population. We are basically at this point just going to continue and pick it up where we left and take a slightly different tack in terms of doing a discussion on diagnostic technologies and ethical considerations in when you are doing whole genome sequencing, for example, in the neonatal population. And before I go too deeply into the agenda, I just wanted to talk briefly about some of the housekeeping items in there. First one is the entire session, and in fact, the entire meeting is going to be recorded, and it's going to be posted on the CPATH INC website. All the on-demand resources, including speaker bios, including the detailed agenda of the meeting, is right now also available on the INC website. So I encourage you to go to the website and take a look at everybody who's going to be speaking today and tomorrow. I really do not expect that there are going to be any technical issues, or I really don't think that suddenly there's going to be a major malfunction or outage for the WebEx platform. But just in case it happens, we do have a backup a plan ready, and if something like that happens, we will email you with backup instructions how to go back online, and be on the lookout if something like that happens. Another point is that it's possible that there might be some pre-recorded videos that we upload onto the WebEx today. If that happens, it's very important that their audio is only going to be available through computer audio, not through phone audio. So as a best practice, please just use your computer audio to listen, not call in using your phone. Then obviously share our event on social media. We would appreciate that. Another important point is if you're trying to log in, and if you have VPN on your computers, would be a good idea to disable VPN, because VPN can certainly cause issues with logging into WebEx. Again, if we do appreciate if you would ask us questions, if you have any confusions, we would like your feedback. So we encourage you to ask as many questions as you have, and just go to the QA panel on the right side of the screen and direct your questions to all panelists so everybody can see the questions. Then this is the agenda for the session today. We are going to have so this session is chaired by Drs. John Davis and Jerry Walkley, and then we are going to have one session on diagnostic technologies, which is going to be presentations by Stephen Kingsmore and Ryan Taft. Then one of our colleagues from Japan, Dr. Toshiki Takinuchi, is going to present results on a rapid genetic diagnosis study in the NICUs in Japan. And then we are going to have a discussion about ethical considerations when it comes to cell and gene therapies, and when it comes to whole genome sequencing and genetic diagnosis in the newborn population. This is going to be by Alison Bateman House and John Lantos, followed by 45 minutes of panel discussion and a QA session. That is the session about today. Then again, tomorrow morning, we are going to reconvene at 10 a.m. Eastern time. The agenda for the session tomorrow is real-world data, and how real-world data promises to accelerate drug development in the neonatal population. So we have a whole agenda for that. I'm going to go over in quite a bit of detail. We'll go over in detail tomorrow. But the idea is that tomorrow the session is all going to be about real-world data. So don't forget to log back in tomorrow for a great discussion on the real-world data. And with that, without any further ado, I'm just going to jump right back into our main sessions for today. And that is about whole genome sequencing, diagnostic panels, and ethical considerations. As I said before, this session is chaired by John Davis and Jerry Walkley. And John Davis is a neonatologist and INC co-director, as well as a professor of pediatrics and vice chair of newborn medicine at Tufts Medical Center. And Dr. Jerry Walkley is the chief of genetic and genomic medicine at the University of Pittsburgh. And now I'm going to invite John and Jerry to come on and provide introductory remarks about this session, why the topics that we want to discuss today are important. So John, if you are online, can I invite you to provide a few remarks, please?
Yes, thanks so much, Kenwalji, and thank everyone for being here on the East Coast. It's 6 p.m., and we know for many people who logged into our session this morning at 10 a.m. Eastern Time, it's been a long day, and so we appreciate you staying with us. This has been one of the more exciting meetings for me because it's not often that you can look at technology that you really feel is going to change the way we practice medicine and change the way we care for babies. And the concept of these new diagnostic technologies using whole genome sequencing and other technologies is really exploding and making a tremendous difference in the way we care for patients. It's wonderful for me as a neonatologist to be partnering with geneticists like Jerry Vockley, like Stephen Kingsmore, and many others. And it really brings a collaborative effort from a number of different approaches to be able to conduct the studies that we need. And what excites me the most is as we're conducting more of these studies and doing more sequencing and making more diagnoses, for those of you that heard Jill Marin described the first 375 patients in our Gemini study that's comparing whole genome sequencing to targeted next generation sequencing platforms. And we're somewhere around 54% of the babies with suspected genetic disorders that we've been able to identify important variants. Not only sometimes for the babies, but even occasionally in the families and secondary findings in the parents as well. So this has been exciting because it's really, to me, unlocking the key. You heard some this morning about treatments for spinal muscular atrophy and some other genetic disorders. And clearly, the earlier you can make the diagnosis and get these treatments to these babies, the better they seem to do long term. So that's our goal. Make these diagnoses more often, identify the highest risk patients. We've had patients with up to 6 separate variants at the same time. Staggering for those of us that aren't used to doing this each day. So we're excited about the prospects. We're going to learn a lot more about it. We're really excited to have 2 very prominent bioethicists with us to talk about some of the ethical considerations for these studies and for doing these genetic sequencing technologies in patients. What's the implication for the patients, for the families going forward? And what are the opportunities to intervene and develop new targeted technologies using precision medicine treatments to try to eliminate or reverse some of these findings. So I'm going to stop here and I'm going to turn it over to my colleague, Jerry Vockley, who I've greatly enjoyed working with throughout our studies.
Thanks. You've used all my buzzwords, so I don't have all that much more to say. I will add that I think we're at a true inflection point in medicine and neonatology as a prime example of that, really leading the way, where we're now in a position where we can clearly bring better care at lower cost. And what more can you ask out of a technology? You're right. The technology here is really driving the whole field forward, but it is still very much dependent on the people who are delivering that technology. So you'll hear some really interesting stories about how leaps of insight also help at times, and we certainly can't forget that there really are still a ton of unanswered ethical questions here. And so that will be a very interesting discussion as we look forward to this new horizon. So I think we best get going and not take any more time from our speakers.
Great. Kanwalji?
Yes, thank you, John. Thank you, Jerry. That was a great introduction. And as Jerry, you said, we should probably not waste too much time going into the actual discussions. And with that, I would like to invite Dr. Stephen Kingsmore, who is the president and CEO of Rady Children's Institute for Genomic Medicine, who's going to talk about newborn screening and diagnosis by whole genome sequencing. And Stephen, if you're online, I'm going to give the mic to you.
Thank you very much. It's great to be here today. Let's get started. I'm going to talk about two things: newborn screening and also diagnosis, both by whole genome sequencing. I agree with Jerry. We are at an inflection point in medicine, and here's the data that supports that inflection point. This graph has 3 lines. The yellow line is the number of known single locus genetic diseases, which just crossed 7,000. The black line is the cost of decoding a human genome in a research setting, which has plummeted to below $700. And then the blue line reflects how long it takes to make a diagnosis by genome sequencing, and that has dropped to 13.5 hours. So this really is an inflection point where even in the most critically ill infants and children, we can now make a diagnosis in time to intervene. Over the last decade, the people have studied rapid genome sequencing, WGS, and rapid exome sequencing, WES. 31 clinical utility studies have been published examining either diagnostic and clinical utility of these technologies. And the results are summarized at the bottom in blue. So almost 2,500 infants and children, mainly in intensive care units, have received these types of technologies in a variety of different countries and different healthcare systems. And the results overall are a rate of diagnosis of 37%, change in management, acute change in management, 29%, change in outcome, 18%. There's very little variability amongst the studies. The numbers do bounce around a little bit, predicated somewhat on the selection criteria, somewhat on the technology, but the overall message here is that genome sequencing or genomic sequencing is having a profound effect in terms of neonatal intensive care unit management. And so we have moved in the last decade from this being research studies, and I've summarized that research evidence on the previous slide, now into clinical implementation. The first country to do so was England, who adopted a policy a couple of years ago to make this a national provision for inpatient infants and children. Wales followed suit, Australia followed suit, and in the US, the patchwork of the sites that we support from our institute in San Diego is shown in the various blue shades, with the number of sites in each given state that send us blood samples, saliva samples, dry blood spots, and medical records to make that rapid diagnosis. I want to focus in on Project Baby Bear, which was published earlier this year, because this is one of the first implementation projects, and the results are very illustrative of the power of the technology. So with funding from our state legislature, we switched on rapid whole genome sequencing at 5 children's hospitals and enrolled about 180 babies, and they reflect the ethnic diversity, the demographic diversity, and the geographic diversity of our state. In 178 babies, 76 or 43% were diagnosed with underpinning genetic diseases that explained all or part of their clinical presentation. More dramatically, though, 55 or 31% had acute changes in care. So not only did we have a diagnosis, an etiology for their underlying pathology, but in addition, we were able to give more specific targeted therapy. And the average time to result was 3 days, as you can see. The second thing that we looked at in this implementation study, now this wasn't research, this was done without consent as a clinical test in a quality improvement setting. The second thing we looked at was cost effectiveness. This was a big concern. How much would it cost Medicaid? These were all Medicaid babies. How much would it cost the system to deliver this at scale? What we found actually was that rapid whole genome sequencing in this population, so this is Medicaid babies in regional intensive care units and with diseases of unknown etiology. That was the descriptor of those who were eligible for this study. What we found was that we had cost savings net and that they were predicated on time to result. The slower the time to result, the less the cost savings. This is a sensitivity analysis that I'm showing you. Second of all, we looked at the other costs saved beyond just the cost of hospitalization, and we found that there were additional savings that continue to accrue. We've now been studying this cohort for about a year after conclusion of the study. They're continuing to accrue cost benefits. So not only is this changing management, allowing us to understand the etiology of these conditions, but it has the potential to actually save the healthcare system cost. And that's largely as a result of babies being able to be cycled through the NICU more rapidly than otherwise. Basically, many of these babies are on a diagnostic odyssey journey, and by telescoping that down to a couple of days, we're able to get them on therapy and get them home sooner. So what's now happening across the country, which is very exciting, is that this is starting to move into the medical mainstream. So Blue Cross Blue Shield was the first national payer, private payer, to support this with the policy shown on the right. And then recently, just in the last couple of months, both Medicaid in Michigan and in California have now either policies or legislation to make this a covered benefit for Medicaid infants. The details are still in development of those, but now at least in Michigan, this is a live policy, and babies in Michigan NICUs will have, who are Medicaid beneficiaries, will have the costs of genome sequencing paid as a carve-out from the DRG. So I want to move on a little bit because for me, genome sequencing is now starting to become medical mainstream in regional neonatology, and to talk about what's next. And so initially when we started this 10 years ago, we really thought it was all about ending the diagnostic odyssey. Could we, for every infant in an ICU, identify the etiology of their condition and get them on optimal specific therapy and thereby minimize morbidity and mortality? However, and our solution was rapid genome sequencing. However, what we found was that we had unveiled a new bottleneck, and that in fact, not all of the benefits were accruing to the children who were receiving diagnoses. And so what we have realized over that 10-year period is the need to regard genome sequencing not as a test, but as a healthcare delivery system, and the upskilling of neonatologists is now of the foremost importance in helping them to practice this new specialty of what we might call molecular neonatology. And so we've examined the problem and defined the barriers, and by and large, our current population of neonatologists and PICU intensivists don't have adequate genomic literacy for many of these diseases. They've never probably seen many of these diagnoses before in a child in their intensive care unit. Furthermore, the literature is disorganized with regard to many of these diseases. Both the information resources, they're individually excellent, but they're not really targeted towards ICU practice. And second of all, many of these disorders are so rare or have been discovered so recently, or it's only very recently that we've been able to diagnose them in a timely manner. And as a result of that, the evidence base supporting many of the interventions for these conditions is not well established. And so what we've been doing over the last several years now is focusing on providing management guidance. It's not enough just to make a diagnosis, and the recent ACMG guidelines are moving us in this direction, where the onus is starting to be placed on the diagnostician to also add treatment information. And so I want to talk to you just very, very briefly about this new management guidance system that we've built that really integrates and summarizes the extant knowledge about management for treatable conditions. So what we've done is to first of all look across our map of known diseases of about 7,000 and identify those that we were able to recognize that there was an effective treatment. We then put them through a multi-step process whereby we reviewed every intervention, surgical, diet, drug, and so on, and measured not just its efficacy, but also its benefits and harms, and finally the evidence supporting those assertions. And we've built this now out as a management guidance system using a web interface to guide clinicians. It's this box 15 here, acute management guidance. And this next year we'll be putting this into practice as an addendum to diagnostic reports. This slide really summarizes where we are at as a specialty today, where in many NICUs we are still gaining awareness of these new technologies, starting to adopt them, starting to retrain our NICU teams in the use of these technologies, then ordering testing. But the future is very exciting because downstream of this is the ability for us to fill in knowledge gaps, such as we're doing with the genome management system, the genetic treatment management system, filling gaps for many of these diseases in terms of our knowledge of natural history, our ability to prognosticate, and also to conduct novel therapy, novel clinical trials of therapies. Lastly, I just want to talk about something brand new, which is moving from diagnostic testing, which has been the norm for the last decade in terms of research, to using the same technology in newborn screening. So again, we have about 7,000 genetic diseases that we know of. We're screening for, on average, let's say 60 of those using newborn screening. We've identified with this virtual management guidance system about 500 conditions that do have effective treatments and are serious enough to put a baby into an intensive care unit, and therefore that probably makes sense to be on an expanded newborn screen, but this time using genome sequencing rather than tandem mass spec. And so that's what we're putting in place currently. We're trying to bridge this gap with a very inexpensive newborn screen by whole genome sequencing. We think that we can do this for probably $200 or $300 in the next couple of years for approximately 500 conditions, and plug this into much of the existing newborn screening infrastructure. And so we are undergoing 4 phases of development along this plan. Currently, we are prototyping this at our institute together with some commercial partners, building the new technologies. We then want to move this into an alpha phase next year, where we kind of work out how to deliver this as a new healthcare delivery system, and then to do an adequate pilot to prove out the benefits, as we've done over the last decade with diagnostic whole genome sequencing. And my hope is that over the next 5 years or so, that this also will become part of care and will allow us to really test every child who's admitted to intensive care units with this type of technology. So let me wrap up. Rapid phenome-assisted genome sequencing is increasingly being implemented for acute management guidance in our NICUs. The impact is, as I have shown you, and in the future, there's a virtuous cycle happening where genome sequencing and early diagnosis are starting to fill in natural history gaps, which are allowing us to increasingly develop new genetic therapies for some of these conditions for which today we lack them. Let me just finish up by acknowledging my co-workers at the Institute. Ad Deo Lumen ab amicis auxilium means to God for creativity, to friends for help. And then lastly, these are the co-authors on a manuscript in press, which summarizes the genome to treatment management system. Thank you very much.
Thank you so much, Dr. Kingsmore. It was really interesting listening to your presentation. And then right after this, we're going to jump straight into the presentation by Dr. Ryan Taft, who is the Vice President for Scientific Research at Illumina. And he's going to be talking about whole genome sequencing for neonates with a suspected genetic disease. Ryan, you're on.
Thank you. So it's a real pleasure to be here. And I'm going to give a talk that's highly complementary to what you just saw from Stephen. So Illumina is a technology company. Our primary technology is sequencing by synthesis, also known as next generation sequencing. And I think one of the most exciting things about this technology, as Stephen already touched on, is the incredible reduction in cost over the last really 15 years, but particularly acute over the last 6 to 7. So just since 2014, we've seen an approximately 80% reduction in cost. The average selling price of a genome today is about $650, but we are on the path to a $100 genome. So our CEO has publicly stated that we now have the kind of technology framework that will get us to a $100 genome in the not too distant future. And if you just do kind of a general technology horizon scan, as Josh Denny and Francis Collins did in Cell not too long ago, you can see that they're predicting that we might have a $20 research genome by 2030. And so as we think about the future of neonatal care, I think we're in a position to think about true democratization of whole genome sequencing based on the changing cost dynamics. The cost of generating the data and interpreting the data is no longer going to be a barrier to getting it into the clinic. We're going to talk about some of those other barriers over the course of this talk. But it's going to shift the entire dynamic in terms of how we think about diagnosing these children. So from a technology standpoint, one of the things we focus on is making sure that the genome is going to be able to provide all of the information that's necessary to diagnose one of these children. So this is a very simplified and high-level view looking at whether a genome is going to be able to detect the variants that are likely to be disease-causing in this population. So we just have variant types along the left as rows, and you can see various technologies as columns. And so if we just start at the top with SNVs and indels, these are single base or small number of base changes, perhaps 3 or 4 letters. And you can see they're addressable by multiple technologies, but also addressable by whole genome. But if we go down this list, you can see that whole genome sequencing has the largest number of ticks. It's going to give you the most comprehensive look at the genetics of any one of these patients. So that's true whether it's a copy number variant, so these are large insertions or deletions, repeat expansions, which I don't have time to spend on today, but these are short repeat sequencing that are often expanded, perhaps for Huntington disease. We're now able to address these with short read whole genome sequencing. We can get structural variants, particularly unbalanced translocations. We can get mitochondrial variants, and we now have mechanisms to get even paralogous sequence, so we can very easily distinguish now between SMN1 and 2, and therefore give the SMA status for a patient. So over the last few years, as Stephen talked about, we've seen a lot of evidence developed in this space, but I wanted to give a brief overview of a trial that we've just completed. This is called the NICU-seq randomized time-delayed clinical trial. And the whole idea here is that we wanted to support the field by developing additional evidence that whole genome sequencing could change management in patients. The time, as you'll see here in terms of the return of results, is a little bit longer than what Stephen talked about, but as you'll see, the impact is still obviously present. Patients were either randomized to the early arm, where they got their results back in about 15 days, or the delayed arm, where they got their results back in 60 days. And the idea here was to use the 45-day window to compare between the two groups. So our primary outcome was the difference in the change in management between the two arms at day 60. Our trial extended to day 90, and the real purpose for that was to do a within-arm analysis in the delayed arm. So the question we were asking there was, even though those results are delayed as long as 60 days, do we see any additional changes in management or any additional increase in diagnostic efficacy? And of course, the null hypothesis for the whole trial is that whole genome sequencing won't impact any of these outcomes. The alternate hypothesis is that because of a presumed increase in diagnostic efficacy, we would also see an additional increase in change in management. The study was conducted at 5 clinical sites. So Rady's Children's Institute of Genomic Medicine was a partner. The PI was David Dimmick, but our patients actually came from Chalk Children's. Luca Brunelli was our PI at University of Nebraska Medical Center, Ian Krantz at CHOP, Chester Brown at Le Bonheur, and Marwan Shinawi at the University of St. Louis. All of the sequencing was done at the Illumina Clinical Services Lab in San Diego, and all of those variant types we talked about before were part of our test definition. In terms of assessing change in management, we saw a gap in the field in terms of a systematic rubric that we could apply across the entire cohort. So this was done in collaboration with all of the PIs that were mentioned and also several other stakeholders. But what we developed was a rubric that if we saw, for example, routine supportive care, that was simply classified as our patients as kind of a dash here in this mock-up, but it wasn't identified as anything that was changing as a result of any precision diagnosis. And then we have condition-specific management, so it's alteration in care based on a primary etiological diagnosis that actually led to a specific treatment specific to the altered therapy. So an example would be enzyme replacement. And then we had condition-specific supportive care, which is another alteration in care, but it's not addressing that primary etiologically aberrant pathway. And then we had palliative or end-of-life management. And the idea here was to do a state change assessment for each patient and then be able to compare across the groups. So this table on the bottom is just hypothetical patients. So hypothetical patient 1 is in the early arm. They're getting routine care at visit 1, and then at 15 days, at day 60, they're getting condition-specific management, and at day 90, they're getting condition-specific and supportive care. For our hypothetical patient number 99 in the delayed arm, you can see they're getting routine care all the way through to day 90, where we're now assessing the return of the WGS result in that arm, and they're hypothetically getting condition-specific care and palliative care. And for the sake of time, I just wanted to focus on the 2 key results. This paper was just published in JAMA Pediatrics, and so if anybody's interested in further information, they can find it there. But at day 60, we can see that the early arm had twice as many diagnoses as the delayed arm. So essentially, your patient was twice as likely to get a diagnosis if they had access to a WGS result. But the surprising thing was that at day 90, we saw the delayed arm catch up. So usual care testing did not catch any additional patients. The entire increase there was as a result of the WGS results that were delayed all the way to day 60. If we look at our primary outcome for this study at day 60, and that was change in management, we see a mimic of what we saw for diagnostic efficacy. So twice as many patients in the early arm had a diagnosis compared to the delayed arm. And again, if we look at day 90, so again, assessing after the delayed arm has seen their results returned, we see a doubling in the number of patients with a change in management. If we look at the types of change of management that we saw in this study, I'll just have you focus on the kind of 2 darker colored bars. So the early at day 60 and the delayed at day 60, which is our primary outcome. You see an increase in the early arm of the number of patients who receive specific medications, who receive targeted therapies, who receive surgery, and the largest number of differences in subspecialty referrals. So as we think about what it's going to take to move this into the mainstream and truly see it democratized, we as a company are really focused on how we establish systems and pathways and a kind of a technological platform that's going to allow laboratories all over the world to do this. And so we really want to focus on a PCR-free library preparation. This is a bit in the weeds, but it's important. If we introduce any amplification bias into the genome itself, we lose the ability to capture some of those variants that we're seeing associated with that increase in diagnostic yield. We want it to be true whole genome sequencing, so as unbiased as humanly possible. We need comprehensive variant calling systems. And then we need interpretation and reporting systems. And from an Illumina standpoint, we want to see all of those components as integrated as humanly possible, so that laboratories are not overburdened by the bioinformatics or computational biology aspects of this. And to Stephen's earlier point, we can really move the needle and move the process further downstream. So we want the diagnostic component of this to be as simple and as straightforward as humanly possible. We're entirely cognizant, though, that there are policy decision and changes that need to be made to support this. There's educational elements, and of course, there's the reimbursement landscape, which needs to continue to move forward if we're going to see this available for every patient that needs it. And so this is my last slide. And what I'm seeing in the field right now is we're seeing a ton of evidence generated in the NICU around the value of whole genome sequencing, that it's both diagnostic, it's change of management, it changes outcomes. And from this base, what we're seeing is a movement either side of that, if you will. So back to newborn screening, as you saw with Stephen, and out into the pediatric outpatient. And we're seeing consortium actually spin up around fetal diagnosis as well. One of our PIs in the NICU-seq study started talking about this as the genomic report card, this idea that this information stays with a patient no matter how early you get it to them. It's going to continue to inform management throughout their life. And that's what we saw in the NICU-seq study. And I think that's what we're beginning to see with some of these ideas around newborn and fetal diagnosis. And so I think it's an incredibly exciting time as the cost comes down. It's going to be incredible to see this as available as I think it's going to be, and the changes in management and changes in patient care that are going to result. So I'll stop there and thank you for your time.
Thank you so much, Ryan. Fascinating discussion, really. And I think, we already have some questions for you, but I'm going to hold off on to asking you those questions until we get to the panel discussion. Moving straight ahead and changing the tack a little bit, I'm actually going to invite Dr. Toseki Takenuchi, who's the assistant professor of pediatrics at Kyoto University School of Medicine in Japan. He's going to be talking about the results of his research and development on precise and rapid genetic diagnosis in NICU study that he's been working on for a while. And I'm so glad that Dr. Takenuchi is here with us and will present the results of his study. So Dr. Takenuchi, you are online.
You converted and then organize this meeting for giving me the opportunity to share our experience on the genomic sequencing in sick neonates in Japan. I'm Toshiki Takenouchi, pediatric neurologist from Kyoto University in Tokyo, Japan. A little bit of my background. I did have a residency in the fellowship in the United States in New York and Boston. And I had a fellowship in neonatal neurology under Jeff Perlman at the New Presbyterian Hospital Cornell Medical Center 10 years ago. And my research has been focused on genetic neurological disorders. And today I'm going to present our data on the national project for the research and development on precise and genetic diagnosis in neonatal intensive care unit. And next slide. Getting the next, no.
So if you go to the left-hand side of your screen, there should be a bar.
This one?
Yeah.
No.
Yeah, so
going down, yes, yeah. Right? Oh, okay. Since many of you may not know much about Japan, I'd like to start out with some basic statistics of this country. Japan has an area of approximately 380,000 square kilometers, which is close to that of state of California, which is approximately 424,000 square kilometers. And Japan's population is 120 million. And whereas the state of California has a population of 40 million. Japan has a newborn infants of 0.86 million per year, which has been declining over the past 50 years because of the progressive aging. We have 82 medical schools and 108 level 3 NICUs throughout the country. We have beautiful 4 seasons, so I hope you can visit us when you get a chance in the future. You will be certainly welcome. So back in 2015, the government launched new funding agency called AMED, Agency for Medical Research and Development, the AMED started the national project called Birthday. Under Birthday, we started a project called Research and Development in Precise Rapid Genetic Diagnosis in NICU in 2019, which is a 5-year project from 2019 to 2023. And the purpose is in order to improve the prognosis of critically ill infants, we perform rapid and genetic diagnosis when the genetic abnormalities are considered to be in the background, and it provides useful information for medical management. We started out with the 8 NICUs in the beginning, and has expanded our network to 15 NICUs so far. And I'm primary investigator of the project. The next slide. So first what we did was we made a provisional enrollment criteria. What we did was we aggregated HPO terms of 122 actionable neonatal diseases, and then listed all the symptoms in the order of frequency, as you can see on the left side. There are many non-specific phenotypes on the top of the list, like seizures, hepatomegaly, intellectual disability, vomiting, hypotonia, etc. And based on this data, and there's some publications from the UK and the United States, we came up this provisional norm and the inclusion exclusion criteria. We know this is very non-specific symptoms, and then we put this criteria for call from clinician into the inclusion criteria. So if the clinician at the bedside feels the genetic diagnosis is important, you just go ahead and enroll to the research project. That's pretty much what we are doing. And in terms of number of participants, well, every month we have 2 to 10 new participants from our collaborators. During the COVID-19 pandemic, we had a bit of trouble in terms of doing the rapid sequencing, since the Central Sequencing Center had a major impact by the COVID-19 and had a complete shutdown for an extended period of time. But things are getting better now, so we are getting more patients than before. This is a summary. So far, we have sequenced more than 100 patients, but this is a summary of 85 neonates who were enrolled in our study. Overall, 41 out of 85 reached final molecular diagnosis, so the diagnostic rate was 48%. And diagnostic rates by subgroups, so metabolic phenotype had the highest diagnostic rate of 67%. Followed by renal phenotype, which is 60%, and the neurological phenotypes had a 58%. And then 4 cases, 5% was meta-diagnosed through whole genome sequencing. They had a small copy number of variations, and 21 out of 41 had a major impact on the clinical management. I'm going to show a couple of examples on the following slides. This is an example of the diagnosis. We had a baby who was very hypertonic at birth and had a respiratory distress. We did the sequencing to identify by allelic mutations in the gene called KLHL40, which is known to cause pneumonia myopathy of neonatal onset. So the benefit of the diagnosis was, number one, we were able to counsel the invasive muscle biopsy for a diagnosis, which was good. And number two, we were able to estimate risk of recurrence. In the conditions with autosomal recessive disorders, the risk of recurrence is 25%. We encountered this information to the parents. And number three, we found the possibility of a treatment. This is sorry. We found a case report from Spain that's this very rare type of myopathy, KLH40-related myopathy, was treated with acetylcholine esterase inhibitors, and they had a positive response to it. And this acetylcholine esterase inhibitor is a medication for myasthenia gravis, which is a neuromuscular junction disorder, not for myopathy, but this report said worked. So we are having discussion to see if this is a possibility for the future treatment. This is an example of changes in the management. This baby was born with white stools and jaundice at birth. And initially, we thought the baby may have some kind of liver disease or some metabolic disorder. And then the liver function was getting worse and worse. So we planned liver transplantation at the outside hospital. And at the same time, we did a whole genome sequencing to identify. This was unexpected, totally unexpected. We found a somatic mutation in KRAS, and this baby was diagnosed with juvenile myelomonocytic leukemia, very rare type of leukemia. So what we did was we canceled the liver transplantation, and we initiated the chemotherapy. There was a big change in the clinical management. This is an example of the diagnosis by small copy number variations. This is the baby who was born with severe respiratory distress and lactic acidosis at birth. And we did the sequencing to identify a very small deletion, biallelic deletions in the patient. And the deletion included a gene called ATAD3, which is known to cause mitochondrial disorder. And the parents, the father and the mother, were heterozygous of this gene deletion. We found that the similar couple of other cases had a similar small copy number variation detected by whole genome sequencing. Diagnostic rates by according to symptoms. Like I said, the metabolic disorder had a highest diagnostic rate of 67%, and the renal 60%. Neurological symptoms is very common, and we had 24 cases, and they had 14 had a diagnosis. Diagnostic rate was 58%. Dysmorphic presentation is also very common. We had 25 cases, and dysmorphic features like characteristic facial features, arthrogryposis, and so on, and had a diagnostic rate of 48%. GI, the hematologic presentation, diagnostic rate was 46%. Cardiovascular phenotype had a lower diagnostic rate of 33%, and overall was 48%. Mode of inheritance. In 41 cases that had a final molecular diagnosis, 56% had a condition of autosomal dominant pattern of inheritance. 29% had conditions with the autosomal recessive pattern of inheritance, and 15% had a X-linked recessive pattern of inheritance. And what was interesting was that we have experience of sequencing in older children, and we had a much higher rate of autosomal dominant de novo pattern of inheritance. So maybe that the reason that we have a higher rate of autosomal recessive pattern of inheritance in neonates is probably autosomal recessive pattern of inheritance has a higher mortality during the neonatal period. That may be the reason I speculate this. And this is my sort of personal speculation, though. changes in clinical management overall, about half the patient had who received the final molecular diagnosis had major changes in clinical management, referral to specialists, screening for complications, new treatment options, and cancellation of invasive testing for diagnosis such as muscle biopsy and skin biopsy, the cancellation of non-invasive diagnostic testing like MRIs and EEGs, and the 4 cases had an introduction of palliative care. So in terms of genetic counseling, before the COVID-19, we had a very strict and closed system. Basically, the genetic sequencing was only available in the level 3 NICUs with full-time geneticists. The reason for this was that we tried to just to make sure the parents have enough and adequate counseling before participating in the study. That was the reason for that. But in the COVID-19, we had widespread of telemedicine and online genetic counseling. So now we are very comfortable using this online system, like what we're doing right now. So we are starting to have more genetic counseling online, so that we can enroll the babies now from the more a number of NICUs. That is what we are doing right now. This is my last slide, future directions. Number one, it's important to shorten the TAT, turnaround time. So what our TAT is around, in the beginning of the project, our TAT was around 8 to 10 weeks. Now the numbers down to 3 to 4 weeks now. So we direct to shorten more someday, but we haven't gotten the point of the level of orders of days, not haven't yet. So we are shooting for that TAT now. And the second thing is the first year of testing. From the technical standpoint, of course, the whole genome sequence is a very comprehensive, and probably the best way to pick up all the structure variants and point mutations. But it's more expensive. So I still think that the whole exome sequence may have some roles in the lower resource settings. And number 3 is we need more research on the pharmacologic intervention. Sometimes we have the treatment option, but that's the off-label use of medication that we need the framework for those interventions. And the last 3, health insurance and reimbursement. All the sequencing is in Japan. It's conducted under research-based activity. So we try to have reimbursement and healthcare insurance so that any sick baby can benefit from the sequencing. Thank you for your attention.
Thank you so much, Toshiki. This was exceptional, really, really great discussion, and your results were illuminating, especially the use of acetylcholinesterase inhibitors for enabling myopathy. Really, amazing. I'm sure there are going to be questions for you coming up, but for now, I'm just going to go straight to the next discussion. And all through the sessions in the morning today and this afternoon, we've heard really great things about cell and gene therapies and benefits of genome sequencing and so on. And then I'm sure that there are we need to think about some of the maybe cons, some of the ethical implications, if there are any. And for that, we have 2 famous ethicists, John Lantis and Alison Bateman House, who are going to be talking about ethical issues related to cell gene therapy and genetic diagnosis. First up, I'm going to invite Dr. Bateman House, who is the assistant professor within Division of Medical Ethics at New York University Langone Health in New York City. She's going to talk about a matter of equity, disparities in access to testing, and downstream implications. So Alison, if you're online, I'm going to invite you to begin your presentation.
here. Thank you. Hopefully everyone can hear me.
Yes,
We had a great conversation earlier today that foregrounded a number of these issues, so I'm glad that I can pick up on themes that we already talked about a bit. I'm Allison Bateman-House. As was said, I'm an assistant professor of medical ethics at NYU Grossman School of Medicine. I'm pulling my disclosures up so you can read them while I have a prefatory remark, which is there's so much exciting stuff that y'all are talking about in this conference in terms of, real tangible benefit to patients and then by extrapolation, their families. And sometimes ethicists come in and start, raising issues, and it's sort of like, well, wait, why are you focusing on the bad stuff and not the good stuff? So I want to acknowledge there's a lot of good stuff here, and I'm not trying to discount it. It's just that sometimes the role of the ethicist is to take issues that everyone is aware of, but they're a little bit off the center of the stage and push them into the spotlight for at least a few moments. So that's what I plan on doing here today. So Jill this morning did a great presentation. This morning, for those of us on the East Coast, during the first session, did a great presentation, and she highlighted a number of ethical concerns that would be relevant to the people on this call in terms of doing whole genome sequencing for neonates. Information like questions like, what information do you release, to whom, when? Do you only give pathogenic information? Do you say you found a variant of unknown significance? How long do you store the findings? What about the incidental findings? If you store the findings, at what point do you, if ever, have to go back and reanalyze that and re-release information as sort of background understanding has changed? All of these are super important concerns, and I promise you, ethicists like myself stand ready to try to talk about them with you. That being said, I want to use my time in the spotlight here to talk about equity. And I'm going to talk about it in three domains. First off, in access to whole genome sequencing, and then to the ability to have that whole genome sequencing produce informative findings for the people who are having it done, and then to the treatment or research opportunities that people may be availed of depending on what that whole genome sequencing found. So I just want to say, this is a very modest goal. It's probably not worded all that well, but just to put it out there, my modest goal as an ethicist would be that whole genome sequencing at some point is going to be equitably available to child patients for whom understanding of their genetics may offer insights with regard to either their clinical care or referral to research or both. And I think we can all agree that whereas it's a modest goal, it is going to be challenging to implement this globally. And sometimes within individual countries, it's going to be challenging depending on, where you live, how you have access to medicine, et cetera. And I just wanted to, show some data to underscore those points, just in case anybody doesn't believe. And I'm sorry this slide looks so dark. This is from a paper in BMJ Global Health this year. I blocked out a bunch of information that was not relevant, but what I want to show you is this is with regard to availability of whole genome and whole exome sequencing, that they weren't able to parse the two. But as you can see, that capability is only available in some areas of the world. There are many countries of the world where this is not currently available. And I think that makes sense to those of us who understand the realities of global healthcare and who gets access to it and who doesn't. But it's still something to keep in mind and to strive for, to say, we have tangible evidence that this can provide benefit to patients, and now we need to figure out a way to make it more available to more patients. Here's a very specific example. Again, this is a recent journal from article from last year here in the United States. This is from Nicholas Children's Hospital in Miami, Florida. I have the citation here if you want to look at it. But what this group did is they looked at two populations within this children's hospital. They looked at the, quote, Diagnostic Odyssey program, who were families who had been referred to and are patients of the genetic clinic, still no diagnosis, and had been offered whole genome sequencing, versus the patients that y'all are talking about, the inpatient ICU patients who, again, were being offered whole genome sequencing in the context of this study. And what they found is they found differences between these two populations in terms of how their care was paid for, the education level of parents, the income of families, and the racial breakdown of who was in these two patient groups. And one thing that I particularly want to underscore, and of course, not of course, but sadly, I have no data to share from the article, is there is this quote in the article, you can see at the bottom, variant burden is significantly higher for non-Caucasian populations. And I wanted to make the point here that what this is showing is there are structural barriers to access. And of course, this is not unique to whole genome sequencing, but it's something that those of you working with whole genome sequencing really will have to grapple with to make the promise as widely available as possible. So in the United States, where many of our speakers have been, coming from and work, we see increasing efforts to make whole genome sequencing available to inpatients. Nicole did a sort of state-by-state analysis earlier today, and that's obviously great. That being said, there's less emphasis on trying to make this available for outpatients at this point in time, and those outpatients may have to proceed in a stepwise manner in terms of having some of these less expensive, less accurate, less comprehensive tests before their payers, their insurance companies or government healthcare programs are willing to pay for whole genome sequencing. So they're built-in structural barriers to access. And then even once you're able to get access, you're overcome whatever the barriers you had there, there's a difference in who's getting benefit from this testing. And that goes back to that quote I had on the previous slide about, differential impact of the findings depending on, whether it was a Caucasian or non-Caucasian population. The reference library that, is being consulted in terms of trying to figure out what these results mean is skewed. It is largely made up of people who have European ancestry. And so we really need to keep in mind the need not only to increase access to the testing, but the need to increase diversity in what information is available for reference. And then, of course, there's this corollary need, which the speaker before me just mentioned, about, you need to have access to genetics counselors. You need to have follow-up care after the testing. The testing doesn't do any good if what it indicates is indicated either in terms of access to an approved intervention or the, possibility of participating in a research study. If those aren't available, then that keeps us from this ultimate goal of being able to help babies through this technology. Here's an example of an approved product, Spinraza. We've talked a lot during the conference thus far about spinal muscular atrophy. So this is, of course, a drug for SMA. This is older data. This is from 2019, but I kept the slide because I think it's important to point out, you don't even have to read it. You can just look at the colors and see that there was differential access and who was getting access to this drug, even once it was approved. So that's, of course, something that we need to strive to increase the reality of access to things, even when they are theoretically available on a regulatory level. And then, of course, when we start talking about things that are not approved, research opportunities, there's a spectrum of access to that too. So this is data from 2020. It's from an article that's under review right now. Earlier today, Thomas Miller, I think it was, showed some data from clinicaltrials.gov, and that's where this is from too. So I'm glad to see other people are plumbing that resource. And you can see, there out of a number of pediatric, this is just gene therapy, this is not cell therapy, but you can see there's, 105 studies happening in the United States, none in Africa, 3 in Canada, 1 in South America. And then, of course, within countries, there's differential access depending on geography as well. And then, how many people get into these trials, even if there are trials available? You can look at this breakdown of the same data, and you can see over half of the trials that I showed on that last map enrolled 10 or less patients. So it's one thing to say, yeah, there's a trial for this genetic indication. It's another thing to say, and you are going to be able to get access to this trial, because in many cases that access is going to be exceedingly limited, and who gets access is going to be a matter of first come, first serve, which gets into these questions again of, who has the economic and social capabilities to get up and go to a trial site, etc. And then, of course, not all genetic findings are linked to identified conditions. And even if they are linked to a condition, not all genetic conditions are the subject of developmental programs. There are no clinical trials for that, for whatever reason, be it scientific or lack of commercial viability. And that's where we get into the last thing I wanted to talk about, which is this new emerging paradigm of individualized medicines. Many of you are probably familiar with this story from 2019 of Melicin, the first individualized therapeutic. It was an ASO for a child with a unique variant of Batten's disease. And as an ethicist, I just have to point out that, of course, if you're going to have individualized therapies, which cost millions of dollars for one person to get access to something, obviously there's equity issues and who gets access to that. And this is an article from the New England Journal of Medicine. This is a quote from the New England Journal of Medicine article about Melicin that just underscores the point that genome sequencing is often pivotal to the diagnosis of rare disease. And before you can go down the path of finding a clinical trial, before you can go down the path of fundraising millions of dollars to have an individualized therapeutic approach, if that's what you need, because there is no relevant clinical trial, you have to at least have that access to the genome sequencing, which is really like the starting point of your marathon. And so, in conclusion, to go back to my modest goal, I said, what ideally would happen is that there be equitable access. And I would encourage us to say that every single one of us has the obligation to say, what is it we need to be doing now in order to make that a possibility with regard to where and to whom this testing is offered, what's in the reference library, where are these research options happening, who has access to approved indication medicines, etc. And so with that, I'll stop and I look forward to the Q&A period. And John, I turn it over to you.
Thank you so much, Alison. Fascinating talk, and some of the things that you talked about were really eye-opening, especially the geographic diversity or lack of geographic diversity when we're talking about some of those clinical trials. And I think there are actually questions coming into you, and we'll get them to you at the panel session. But for now, I'm going to go right down to the next session by Dr. John Lantos, who's the Director of Pediatric Bioethics at Children's Mercy Hospital in Kansas City. He's going to talk about genomics and redirection of care. So Dr. Lantos, you are on now.
Thank you very much. Just trying to think if I can get my slides to advance here. Oh, there we go. So redirection of care is the most common clinical action that results from molecular diagnosis in a sick child. And I'd like to talk a little bit about some of the ethical issues that may raise. When you think about genomics and withdrawal of life support, some of the questions I think we need to ask is whether the genomic information on which this is based is accurate enough. And maybe more importantly, should we consider initiation of palliative care to be a benefit? Many of these studies talk about change in management as one of the positive findings from these studies. But if the change in management is that the baby will die sooner, it at least raises the question of whether the decision to redirect care was based on accurate information and whether that should be considered a benefit. If you look at what doctors say about this, practicing clinicians have a lot of concerns about this. Danton Shar is a cardiologist at Stanford who interviewed a lot of docs who were pioneers at Stanford's pioneering program. And they said things like this: often we find a deletion or an addition or balanced translocation we don't know exactly how to counsel for. There's not enough data out there for what that particular deletion or addition means. And right now we are often flying blind. Shar talked about how doctors worry about the uncertainty and how that creates moral distress. The moral distress creates some burnout, and how the introduction of whole genome sequencing might be accelerating burnout as doctors are overwhelmed by the information and forced to make decisions under conditions of radical uncertainty. There are also some blurred boundaries between research and clinical care that change the relationship between patients and health professionals. Many of these studies are done by experts in genome science, but many of them are not practicing clinicians in the NICU or the PICU. Once we get into gene therapy, these lines become even more blurred. And it's interesting to note that although there's a hope that these will lead to gene therapy, and hope that the changes in management that come about as a result of genome sequencing will be beneficial. There's not a single study yet that shows any improved survival as a result of all this effort to come up with more accurate molecular diagnoses. In fact, as a result of the most common finding being redirection of care, there's generally decreased survival with increased use of genome sequencing, especially with rapid return of results. Many doctors still see redirection of care as a benefit for babies we know have a fatal condition. We wouldn't want to prolong their suffering. I'm not going to deny that. Only going to ask whether this raises some of the sorts of questions that bioethicists are familiar from debates during an earlier era of genomic pioneering, that is the era of karyotyping and chromosomal analysis, which enabled earlier diagnosis of Down syndrome and the whole controversy about baby doe. So we have to ask, how certain are we that a particular genomic variant provides certainty that the disease is fatal and the treatment is futile? Let me just give a couple of examples that illustrate my concerns. This is sort of a composite case from two different papers, but interestingly, they both described a similar situation. Baby was born around term, had multiple dysmorphic features. Genome sequencing revealed a variant associated with one of these rare Mendelian diseases called Coffin-Siris syndrome. It's a syndrome associated with moderate intellectual disability, but intellect in the normal range as well as severe disability have often been described. Given this information, the parents elect not to proceed with heart surgery, to redirect to palliative care. The baby was managed palliatively and died in infancy. Coffin-Siris syndrome, as I said, has this wide range of outcomes that are quite similar to the range of outcomes in Down syndrome, and it's not usually a reason to initiate palliative care. There's a foundation for Coffin-Siris syndrome. There are parents who are passionate advocates for continued life-sustaining treatment. So one needs to question whether the decision to redirect care based on this molecular diagnosis is an ethically appropriate decision. Another case, full-term baby, had bilateral chylus effusions. A gene was found that was associated with Noonan syndrome. Here's the variant, and based on that, they made the diagnosis, even though there is some uncertainty about the penetrance and expressivity of this gene. There's many genes associated with Noonan syndrome, and no population studies know how common these variants are in the general population, and very little knowledge of penetrance or expressivity. Again, Noonan syndrome has a wide range of clinical or phenotypic outcomes. Most children with Noonan's grow up and function normally in the adult world. It too has a foundation and many parents who are passionate advocates. But in this case, based on this diagnosis, at least according to the report, care was redirected towards palliation and the baby was allowed to die. Now, did they withdraw life support based on the molecular diagnosis of Noonan's? If so, that would be questionable clinical care. If not, was the genomic result a contributor to the decision, or should it be? It raises the question of whether the new genomics could become the basis for something that looks a lot like a new eugenics. Whole genome sequencing allows earlier declaration of futility, better guidance in decisions involving withdrawal and rationing of scarce resources, and it's often cited as an example of the clinical usefulness of whole genome sequencing. As I say, whether this is a problem, I think we have to compare it to the history of the response to trisomy 21, where the diagnosis in the past was used to withdraw life-sustaining treatment. That has changed. We now think of trisomy 21 as a condition for which withholding life support is no longer ethically justifiable. But with the new genomics and hundreds, thousands of new molecular diagnoses many of which are associated with conditions quite similar to Down syndrome, I think we will be forced to revisit some of the questions that arose in the Baby Doe debates about parental rights, about doctors' complicity in advising parents about withdrawal of life support, and questions about how well these tests predict the future quality of life and therefore the best interest of the child. People have started to think about this in relation to trisomy 13 and 18, but I think with whole genome sequencing, it's going to be a much broader set of conditions. My only take-home point here would be to maintain a questioning and critical attitude about the way these exciting new tests are used in light of the disastrous abuses that have been carried out in the name of genetics by professionals and by an entire social system in the past. I think I'll just stop with that and look forward to discussion.
Thank you so much, Dr. Lantos. Fascinating presentation indeed. And we will get right back to the questions that might have come in for you. But in the interest of time, we're just gonna jump straight into the panel discussion now. And all of the presenters who have presented are actually a part of the panel, but you've already talked. So I'm just going to introduce a couple of new individuals who we have assembled as panelists. And what I'm going to do is I'm going to introduce them and then invite them to present a brief perspective from their side. And once that is done, then we'll go on to the question and answer session. So the panelists that we have today are, first one is Dr. Maria Escolar, who's the professor of pediatrics and neurodevelopmental disabilities at University of Pittsburgh. Then we have Dr. Jerry Baer, who's the Supervisory Medical Officer, Pharmacovigilance and Neonatology within Office of Pediatric Therapeutics, Office of Commissioner at FDA. Then Dr. Jeff Barrett, who is the Senior Vice President and Head of Rare Disease Cures Accelerator at Critical Path Institute. Then we have Chip Chambers, who's Assistant Clinical Professor of Surgery at Vanderbilt University and the founder and president of DATA2 Foundation. Then Cindy Prowse, who's a genetics clinical nurse specialist at Cincinnati Children's Hospital Medical Center. So first up, I will invite Dr. Maria Escolar to present a brief perspective, and I think she has a couple of slides too. Maria?
Yeah, thank you very much. This is going to be a fascinating, I think, discussion. So I'll just tell a little bit about my perspective as a neurodevelopmental pediatrician who directs a program where we only see children with neurodegenerative fatal conditions that are genetic. And in my world, a lot of these conditions affect the brain really early. Sometimes they have injured the brain pretty severely at the moment that they are born. These children can die within 2 years. Very few of these are included in statewide newborn screening programs, and therefore you may find them in your neonatal ICU when you are doing this type of testing. New therapies have been developed and have failed to demonstrate positive treatment effects because the brains are already injured at the time of diagnosis and therefore at the time of therapy. Newborn screening is not considered many times by the RASP when you don't have a therapy available. So we get into this chicken and egg situation where therapies cannot be developed because you don't pick them early enough. And when you try to develop them, the outcomes are not good because the brain is already too injured. Oops, sorry. So for those conditions where there is newborn screening, we're going from diagnosing based on symptoms to diagnosing based on, let's say, mutations. But we have very few correlations between sometimes mutations, if it's an enzyme deficiency, or even when the disease is going to present, if they're going to present as a infant, as a juvenile, or as an adult. For many of these conditions, we also don't have biomarkers, and in some, you may have a disease that can affect the brain, for example, Hunter syndrome, or maybe it affects only the body, so you would have only the somatic disease. So you would have treatments that may be very risky and aggressive, for example, transplantation or gene therapy, in which you have to then decide based on what you know without waiting until there is already severe injury. So these neurodegenerative conditions are fatal, progression can be rapid, and early diagnosis and treatment necessary for good outcomes. So some of the questions that I think could be good to discuss that I put in here was issues such as conditions that are screened neonatally. If there is no treatment developed, is it a good idea to be diagnosing them? Then if you only have treatments where there is significant risk, or you have treatments that are investigational in phase 1-2 clinical trials, what should be the best practices in terms of counseling the families? When newborn diagnosis is established, who is responsible for then monitoring these children long-term for those conditions that can present later in life, knowing that if we're too late, there would be a lot of brain injury and functional outcomes are not optimal. What should we be putting in place to track current decision process and outcomes to improve future practice? I think we have to put as much energy into many of these questions and some of the ones that were mentioned by the two ethicists, as much effort in this area as we would put in the early diagnosis, because our journey is going to be difficult once you go from screening a population to actually following them and understanding how they would present. We would need natural history studies, much more biomarkers developed, and a lot of education in how to counsel these patients and families.
Thank you so much, Maria. These are indeed important questions, and I think we will try to address and get to these questions during the QA session today. But continuing on to the panel discussion, Adriana, can we just change the slides, please? Alrighty, so thank you. So the next one on the panel list is Dr. Jerry Baer, who's, I said, Supervisory Medical Officer, Pharmacovigilance and Neonatology in the Office of Pediatric Therapeutics at FDA. So Dr. Baer, would you provide an FDA perspective on this as well?
Sure. Thank you so much, Kawaljit, and thanks to the speakers and the organizers for this incredible day of sessions. I will start with a disclaimer that I am not an expert in genetics, and I'm not exactly sure what I have to add to this panel. However, there are a few sort of resources that I think I can speak to from an FDA perspective. We have, if you're considering studies in this area, there are a ton of guidance documents in both the rare disease space and also in the gene therapy investigative space. And, you know, for most people, these are not exciting reading, but if you're looking at ways of designing a study, enriching populations, getting input from families, these guidances can be incredibly helpful. One of the important pieces of that, and Maria just mentioned it, is how to develop a natural history study. For these kids who have a genetic diagnosis that is symptomatic, who don't have a treatment option, one of the best ways to improve the field is to enroll kids in natural history studies. And so one of the guidances has terrific instructions on how to complete a natural history study. And this brings me to the last kind of point that I wanted to make, which harkens back to a talk that John Davis has given a few times, but I remember him giving very early in Inc.'s life, which is that every baby needs to be in a study. So if these babies are getting early genetic diagnoses, they all need to go into some kind of investigation, if at all possible, so that we can follow the natural history, so that we can develop biomarkers, so that we can develop the ethical guidance in terms of how to proceed and how to cope with these diagnoses. And so as we get more data, as our presenters have shown today, lots more diagnoses. We need to collect information so that we'll know how to approach these kids moving forward. Oh, and one last piece, which Maria also mentioned, is the importance of parents, survivors, and advocates in decision making and in understanding what is important to families and survivors. So thank you, and I look forward to hearing from the experts.
Thank you so much, Jerry. Your points, every baby needs to be in the study, as you said, and John said, incredibly important. And then having them participate in, if possible, natural history studies, really, really crucial. And, we agree with you. And then we certainly will look at the guidance documents, and then probably would be a good idea if we can just, at the end, when all of the the meeting materials are ready, we will probably try to incorporate the links to some of those guidance documents for the for the audience who wants to look into and look into the videos that we're going to be posting, and having them accompany the guidance documents would be a good idea as well. So thank you so much. It was great hearing from you. And next up, I'm going to invite Jeff Barrett, who is the rare disease guru at CPATH. I'm going to ask him to present CPATH perspective as well. So Jeff.
Thanks, Kanwaljit, and thanks to the speakers in this session. It really highlights the importance of this kind of data and the sensitivities around data too. My perspective is going to come from the effort around creating a hub and a platform to house a diverse set of rare disease data. Recently, in fact, just a month ago, we launched the RDC-ADAPT platform as a home for the rare disease ecosystem that includes mostly data from electronic medical records, registry data, natural history data, completed clinical trials. But a real frontier area is, in fact, in the genomics data arena. One of the things that we know, like many have pointed out, is that we're not genomics experts. We do have genomic background and expertise, but this is not a place to reinvent the wheel. So one of the things that we're doing in terms of future efforts to expand the functionality of the platform is to look for partners to help us manage and handle the analysis of genomic data. So a big effort ongoing now is to take a look at existing platforms, and there's several of them for consideration. I'll give you some examples: Gene Data Profiler, the Broad Institute, TAC at the University of Texas, Monarch, Varsum. These are all service providers who handle specifically genomics data, and they actually have quite a bit of genomics data. Now, I would say a small subset of this is neonatal data. So some of what will happen in the future, hopefully, is that more and more of this will get accumulated and become a part of the existing platform. One of the efforts on our behalf is to build connectors for the RDC-ADAPT platform to these other providers so that there's a seamless pass-through of the data. There's many issues to be resolved. The ontologies make a difference. How the data is stored, the giver's concern around data privacy. All of this is part of our vetting process that we're going through right now. And the real reality is that we can't just pick a single winner here. We really have to work with everyone because there's such a small amount of this data in general. We have to find a way to have all of this become available to the broader community. So details around where the data is stored, how the data is stored, and how the data ends up being rolled into larger data sets that are integrated with other sources of data, as we talked about. So there's a lot of dirty work that has to be done to connect the data and ultimately make it available for broader use. Now, a big emphasis for the RDC-ADAPT effort is to build tools that facilitate rare disease drug development. Those could be disease progression models, clinical trial simulation tools, other summaries of this kind of information. That's why the issues around data quality are so important, but also in terms of the provenance and the care around this data. So this is clearly a work in progress. And I'm so thankful to be part of this session because the issues around the ethics are very clear and a real issue. The data privacy piece is certainly an issue as well. We would like to be able to use this data in a broad manner, but there's a lot of tires to kick before we're ready to do that. So I look forward to the discussion.
Yes, thank you, Jeff. Absolutely, I agree with you. And in fact, this is something that I always wanted to do as INC gets deeper into this genomic space. A collaboration between RDCA and INC is just a logical next step, and we'll keep on the discussion and dialogue going on. So thank you so much for coming in and providing your perspective today. Next up is Dr. Chip Chambers, who is the Assistant Professor of Surgery at Vanderbilt University and founder of the DADA2 Foundation. Chip, if you are online and can hear me, I would love to have you online and present your perspective.
Thanks, Kenwal. Thanks to everyone, John and Jerry, for this amazing conference. My name is Chip Chambers. I'm the former chief of endocrine surgery at Vanderbilt University Medical Center, which I believe qualifies me as the only endocrine surgeon that's ever attended an international neonatal consortium meeting. I just want to say that. But more importantly, I am the father of 2 children with a rare disease called deficiency of adenosine deaminase 2, which is a monogenetic autosomal recessive disease with a loss of function of the ADA2 protein. Phenotypically, that can cause autoinflammation with vasculitis, stroke, liver, kidney injury, immunodeficiency, and even bone marrow failure requiring bone marrow transplantation. And so there have been some great talks, and Stephen, I sort of harken back to your talk about the impact of the cost on the medical system. I want to just for 30 seconds just expand that to cost of society and have us think about rare disease different than that classical 7,000 number that's discussed, right? So based on that, there's about 25 to 30 million Americans affected by rare disease. So that's roughly 9 to 10% of the American population. So if you look in the studies for the past 30 years, the average birth rate for a woman in the US is about 2 children. Therefore, each biologic family would have about what? 4 people. Now, if you use the biologic family, you can sort of get around the complexities of divorce, remarriage, these kind of issues. So that really gives us a number of 36 to 40% of American families that are affected by rare disease, not just the index patient. So that comes to about 132 million people in the United States. And I can certainly speak personally that our family was on a 15-year diagnostic odyssey, and I have access to everything, right? Because I'm a physician. Imagine those families out there that don't have access or don't have the resources. And so when you start thinking about this in the grander scale, trying to get to a diagnosis is very important. But I believe Chris Austin said, who the former head of NCAT said, that if we started working today at top speed, it would take about 2,000 years to come up with a treatment for all 7,000 rare diseases. So I say that not in a negative, because I'm certainly in favor of early diagnosis and early research to drive toward a cure. So very unique perspective, and great conference, guys, and really impressive speakers. I'm humbled to be a part of it.
Thank you so much, Chip. We are honored to have you on the panel as well and provide your perspectives. We have one more panelist left, and that is Cindy Prowse, who's a genetic clinical nurse specialist at Cincinnati Children's Hospital. Cindy, if you are here, can hear me, I would love to have you online and present your perspective.
Hi, thank you. Like Chip, I am very humbled to be part of this esteemed panel and speakers. I had prepared some things to say and crossed much of it out because it's already been said. But one thing I can add as a nurse is to consider what the parents are hearing and that they are making decisions under a lot of stress. Early in my career, in my training as a clinical nurse specialist in genetics, a father told me that what he heard when the counselor was talking to them and showing pictures and going into all this detail was, I heard the diagnosis of Down syndrome and everything else was white noise. And we are talking about identifying very rare conditions and asking parents to do decision making when they are under all that stress. Also, many of these parents are going to be hearing negative results, and we've been focused on positive results. And so one thing I would encourage is to make sure that there is at least one nurse that is with these parents when they are being told the information, so that nurse can be their ear and can ask and do follow-up questions later on when the parents start asking all their questions. And finally, there was a little bit of a mention of the opportunistic analysis that is done with sequencing to look for conditions that are totally unrelated to why the sequencing is being done. And some of those things are adult onset conditions like breast and colon cancer. And I advocate for delaying parents having to opt in or out of those secondary findings at a time when they're in crisis, and encourage storage of whole genome sequencing data to be used when it is age relevant or in some other kind of clinical, as new clinical indications occur. Thank you.
Thank you so much, Cindy, for your perspective. We have like around 22 minutes, 23 minutes left into the session today, and several questions have come in, including the questions that were posed to us by Maria Escolar. And let's just jump right into the QA session. And what I'm going to do is I'll read out loud those questions to you all. I'll start with the questions that were put up by Maria, and then probably would be a good idea if I'm going to pose those questions to everybody in the panel, and whoever of you feel like you would like to answer this question, please just raise your hand, like physically raise your hand, and I'll ask you to answer that question. So the first question that was posed by Maria Escolar, that was in response to some of the multiple rare monogenetic conditions. So the question that she had was that should such conditions be screened neonatally if there are even no treatments developed now or in future? I would love for the panelists to provide their thoughts or feedback. What do you guys think about that?
Well, I'll start, Kanwalji, while
Yes,
our
please,
folks are coming on, and then I'll turn it over to John. I really do think it's important. The uncertainty that we face sometimes in the neonatal intensive care unit can be overwhelming. And for parents, they really want to know a diagnosis for their child. And sometimes that means continuing to do other blood tests, do other imaging, keep the baby in the hospital. And if we do find out that there is a specific diagnosis, many times, and this is one of the things we're looking at in Gemini, is that we're able to stop all the diagnostic testing because we seem to have found the answer. Some of the times that means letting the parents go home with their child if it is no specific treatment that can be offered. So I do like the idea of at least being able to give the parents an answer, because sometimes parents lose their children and never know, even after an autopsy, what that diagnosis was. And we have found in Gemini that as many doctors and families are appreciative of not getting a diagnosis than of getting a diagnosis, because then maybe it isn't a genetic diagnosis, or it might be something different. So I'll be interested to hear what other folks think, but I still believe that making that diagnosis is important.
Thank you, John. And I think Dr. Lantos has update to this question too.
I think I interpreted the question a little differently, but if the question is, should we be doing population-based newborn screening using genome sequencing, I would say that's nowhere near ready for prime time. What John Davis is talking about, I think, is diagnostic testing for sick babies in the NICU, and there I completely agree. Dozens of studies show that parents desperately desire knowledge, even if the knowledge means that there's no effective treatment. But for population screening, I think the most important data comes from the Harvard Baylor BabySeq study, where they did do healthy newborns and found that 7% of completely healthy newborns had genomic variants that were classified as clearly pathogenic. If that was extrapolated to 3 million births a year, it would be a crazy mess of counseling under conditions of radical uncertainty that I think would do a lot more harm than good.
But I think that's not
Thanks,
what
John.
Stephen was proposing in his talk, and I think if it would be worth Stephen, you reiterating your proposal to screen for basically about 500 things where there was an opportunity to intervene in the newborn period.
Sure, I'd be happy to. Yes, that's exactly it. So we currently screen on average for something like 60 conditions in conventional newborn screening. And what has happened is that we now have effective therapies for more conditions than we have assays for. And either we continue to build out newborn screening in the traditional manner, assay by assay, and that's taking about 6 years per test to get approved and then into the system, and spinal muscular atrophy and Duchenne muscular dystrophy are the two that right now are on that 6-year journey. We have effective therapies for them, but many states, a majority of states, don't have tests for them. So it's to fill that gap. It's not to screen for all kinds of conditions. It's very much focused on, we have a proven system. We've been doing it for 60 years. But the technologies have advanced now where we can look at genetic conditions as well as metabolic ones. Thanks, Jerry.
Yeah, thanks, Stephen. Thanks, Jerry. Again, just a request to all the panelists that would be a good idea to switch on your video so we can actually all see you. And if you have any, if you would like to respond to any of the questions, just please physically raise your hand and then I will call you upon. Does anybody else have any thoughts about this question? If not, then I'll go on to the next question that Maria had posed. Okay, so then the next question from Maria was that if only treatments with significant risk are available or they are investigational, that is in early stage phase 1 or phase 2 clinical trials, what should be the best practices to counsel these families? Any thoughts from anybody in the panel?
I'm happy to dive in
Yes, Jerry.
into that one. I do a lot of clinical trials for rare diseases, and it oftentimes, although the number of patients that are going to be enrolled in those is actually quite small, as was pointed out. It can be very difficult to recruit to those, because especially if the need for treatment is rapid. We have a lot of disorders where we can stabilize or actually treat, though in a maybe a less perfect way, for a long time, and those you have the luxury of moving more slowly. So if you're talking about a condition, maybe one of the 500 that are already on the list that Stephen has created, or or something else that's coming down the road that's not yet available. I think you have to be able to recruit to those rapidly, and in talking to families about it, it's like any research study. There's no absolutes, but if there's no other treatment available, it becomes an option for them that they wouldn't have otherwise.
I think, Jerry, and I agree with you. And again, Jerry Bear has a wonderful memory and remembers the talk that I gave several years ago, but I used the cancer example. You know, if a parent brings a child in with cancer, they're offered a protocol for it, and they almost never say no. And I think that's why they've made such huge gains in the treatment of cancer or childhood cancer over the years, because it's rare that they lose a patient. And yet we really struggle to get babies into these trials. So it is fascinating, and I agree with you. But I'd be curious too, what some of our ethicists and Chip, I think you're a good person to answer that question, because if someone came to you now for your children and said, we've got an early phase trial and we think it may work, you know, how would you respond to that?
Yeah, John, it's a great question. And again, I've had the honor and privilege of talking to DADA2 patient mothers and fathers around the globe, from Romania to South America to Nepal to Kentucky and everywhere in between. And I would agree with you. I've often described it this way. If you've never seen a rare disease mama, you've not seen a mama, because they will go as anyone would for their child. They will go gangbusters. They will raise the money for the clinical trials. You know, they'll have bake sales upon bake sales. They'll contribute their data. They'll contribute their family's data. They'll send you their medical record, because it's their child, and they're willing to do almost anything to support the research that may or may not give an answer for number one, what's wrong, the diagnostic odyssey, and number two, is there any possibility of treatment? It just so happens that for the autoinflammatory phenotype of DADA2, we're using TNF inhibitors to treat that. And that was serendipitously discovered by the Israelis in a group of the Georgian Jews they were following, when a child in the PICU was 2 years old and dying from perforated bowel from DADA2. And the kid next door was getting that brand new drug that had just hit the market called infliximab, the first TNF inhibitor. And we would all go to jail for this in the US, but they had some left over in that bottle, and they gave it to that 2-year-old Georgian Jewish boy, and he started to get better. So no science, no clinical trial, no nothing, but it's actually the standard of care worldwide to treat that phenotype of DADA2. So they'll do anything, and then they'll take drugs totally off label with information like that. So I couldn't agree with you more.
Jerry, I know you didn't mean to be negative, because you said you didn't mean to be negative in the beginning of your talk. How would you how do you view that pie chart where you have so many diseases and so few patients and a limited number of treatments? How do we deal with that in the context of John's consortium that needs to put every baby into a treatment? Because I give the same talk, John, how do you see that? How do you present that to families? How do you present that to physicians who may not have a broader view of rare diseases?
Is that directed to me, Jerry?
I was actually, well, you can answer too, Chip, but I was sending it back to Jerry, because she had proposed it in her talk.
Yeah, Jerry, that would be great. You tackle that one.
Or was that Allison who said that? I'm sorry.
I think it was Allison.
Allison, I'm sorry.
Allison,
I had to look at my playbill to see who the cast of characters were. I'm sorry, Allison.
No worries. It's an honor to be thought to be Jerry. So thanks, Jerry, for sharing your identity with me. So, I mean, I guess the only thing I would say is clinical trials and the opportunity to be a part of research is a two-faced thing. Like we always think about research as a positive, but there are negatives, right? And so I just think it's important for people to understand upfront that whether it's research that involves, testing. Once you learn the results, you can't unlearn them. And you just need to be aware that that can have consequences not only for this particular child, but for other family members. And as long as people are aware of that, then go ahead. And then when you start actually talking about interventions, keep in mind choosing to do one intervention probably forecloses doing another intervention. So I spend a lot of time doing gene therapy research. If you participate in a phase 1 gene therapy trial, which, we mentioned earlier, SMA, pre-Spinraza, whatever, was a fatal, rapidly progressive disease, people would not say no to that because they didn't see any other option. But as the standard of care changes, as options come up, suddenly things may not look as appealing anymore. Or, if you had a longer disease like Duchenne muscular dystrophy, right? You may not want to enroll in that phase 1 trial because you don't need to make a decision right now. You've got a longer time horizon. But once you do take that gene therapy intervention, you're probably not going to get in any other clinical trials, whether they're gene therapy or anything else. And if a product comes to market that's not the one you took, you're probably not going to be able to take it because you have antibodies. So I just want people to understand up front that, research is great. And really by participating in it, you're pushing forward on behalf of a population. It may not help you and it may actually foreclose some opportunities for you or your family. So hopefully that helps a little bit.
Right. Thanks, Alison. And I think John Landis had a point about this as well, right, John?
Just to say that I think the paradigm of childhood cancer is not going to work for rare diseases because the numbers are so small. So I think the challenge is going to be figuring out what good studies are going to look like if, as they generally are in this space, they're not prospective randomized trials and they have an N of 12. It's mostly going to be historical controls. It's mostly going to be surrogate endpoints. And it then leads to all the problems we've seen both with COVID, but also in the popular media with things like Lorenzo's Oil and Dallas Buyers Club, where people passionately believe that some drug is effective when the limited data suggests that it's not. And that's going to be both a regulatory as well as doctor-patient communication and ethical problem.
If I can just hop back in just to say one more thing that John made me think I wanted to say. At least one of the panelists mentioned the importance of natural history studies. And, when you do have to use a historical control, if there's not already that data there, we need patients to be enrolled into natural history studies right now. I also don't know many people who are enthusiastic about enrolling their child into that because, well, where's the benefit for me? Why, sure, it sounds good, on one level, but it's time for my family, it's expenses of, potentially traveling back and forth. And I don't want to foreclose the opportunity to be in a potentially therapeutic trial if that comes up. So I just think as a community, we have a lot of work to do to make people understand why those studies are worthwhile.
Allison, this is Chip. I think one of the big
Go ahead,
things.
Chip. Sorry.
No, I just was going to say quickly that, it's something that the medical community is not familiar with, but that's working with these rare disease foundations because they've thought through a lot of these issues and even addressed them with their community. And I think physicians are a bit uncomfortable, not everyone, but uncomfortable at times saying, well, I'm going to involve this rare disease foundation for X disease in the design of my study. Where you can really get real world data. But again, you will find them ready, willing, and able to help. And they have access to the patients, whereas you don't oftentimes.
Right.
Yes.
I'm going to cheat for a second here because I know that Maria is in the same department as me and really runs quite a large natural history program as part of her research. I think it would be great to hear from you, Maria.
Yeah, well, so I do believe that it's very important to do these natural history studies in a standardized manner so that the data is good quality and you can use it actually for FDA approvals. But when I posed that question, I was thinking of two aspects. The one we have discussed, and the other aspect is how do we counsel these families? Because all the points that you made were extremely important, and they don't necessarily come up. And depending who counsels this family or who consents the family, not everything is in that consent that we get IRB approved, right? So to make a point, for example, with what Allison said, you know, some babies get the lower dose in these clinical trials that maybe won't have an effect. And so, you know, they're making that one-time decision. And because they have, in the case of the patients I see, a neurodegenerative disease, they become desperate. The communication part is extremely important because, for example, you are bringing a very bad diagnosis, and as someone said before, you know, everything becomes gray and they don't hear much about what is the next step. Then you come up with a new therapy, or what, in some cases, when the standard of care may be a risky therapy like transplantation, you are introducing three big concepts in somebody who's just had a newborn baby. So this communication part is, I think, very, very important so that we are ethical in how we do these things and help families go through all this decision process, which most physicians, I don't think, may understand. And if we hear from families, you know, I hear that exactly, you know, this is, I hear the first news and I can't hear anything else. And so how do we go through this process of making sure they have the time, the understanding, and then make a decision when they are fully educated about what they're doing?
Right. Thanks, Maria. Just I'm looking at the time that we have 3 minutes left, but I do see that Jerry Bear had raised her hand, and I think, you know, Jerry, you have a point to make. Can I ask you to
Very
speak?
quick, a couple of very quick comments.
Yes.
The natural history studies could be a segue. This is a response to what Allison was saying. Could be a segue to access to the next trial. You know, to you know, just being hooked in with the community and being hooked in with the academic institution, and being, you know, first on the list for that next potential treatment. And to as a quick response to Maria, is the agency, FDA, is well aware of the issue of dosing, and does, you know, we do everything we can to ensure that no one who's enrolling is getting a dose that we don't believe would be effective. Obviously, there are limitations to that knowledge, but that's something that the agency is really clued in on, and we don't want to enroll children if they're not going to have a potential benefit.
Right. Thank you, Jerry. This was absolutely right. You know, having someone participate in the natural history study is their, I guess, you know, gets them to the front of the line for the next clinical trial. A really, really great motivator, so to speak, for someone to have their kids participate in those natural history studies. Absolutely agree. And you know, this has been a great discussion, really excellent back and forth discussion, engrossing. All of the sessions in the evening session as well as in the morning session today were really excellent. And I would like to sincerely thank you all for your time today, and understanding that on the East Coast it's almost 8 p.m. So, you know, again, really sincere thanks to you all for your time today, and for your giving us a bit of your expertise. And it was great to see you all. And again, you know, this isn't the end for the INC annual meeting. We are going to be reconvening again tomorrow morning at 10 a.m. with the focus of the discussion is going to be real world data. And for real world data, because as you know, there's a lack of clinical trials in the neonatal space, right? So how can real world data plug some of that gap? So that is going to be one of the points for discussion tomorrow. I do hope sincerely that you would be able to join in and listen into the discussions tomorrow. Yeah, it's been really nice to see you all, and also thanks to all of the audience who stick with us late at night, and for some of you, it's been like really early, especially for our Japanese colleagues. So thank you so much, everybody, again. Great to see you, and I look forward to continuing this discussion way beyond the purposes of this annual meeting into the future collaboration with you all. Thank you.
Thank you.
Thanks so much, Kanwalji.
Thank you so much, everybody.
Thank you.
Thank you.